You know, we all hear the term heart attack, right? But what does that actually mean? What's happening inside your body when one strikes? Today, we're going to demystify the whole thing by looking at what doctors call acute coronary syndrome, or ACS. We'll explore that minute-by-minute battle to save a life.
So, to really get it, let's follow a patient's journey, right from that first scary twinge of chest pain. We're going to look at the biology of what's causing the blockage, the intense, high-stakes race for a diagnosis, and the pretty incredible strategies doctors use to save that precious heart muscle.
So, how does this all kick off? You might think it's this slow, gradual process, but it's not. It's a sudden, catastrophic event happening inside a tiny but absolutely vital blood vessel.
At its core, acute coronary syndrome is basically a plumbing problem, a really bad one. The coronary arteries, those are the pipes that feed your heart muscle all the oxygen it needs, and they suddenly get blocked. This isn't some slow clog that builds up over years, it's a sudden crisis, triggered by something breaking inside the artery wall.
It all unfolds like a domino effect in 4 really critical steps. First, one of those fatty deposits, a plaque, inside the artery suddenly cracks open. Your body, well, it freaks out. It thinks it's a major injury, so it launches its emergency repair system. Platelets rush to the scene to form a clot and patch the hole. But here, that hopeful response goes into complete overdrive. The clot just keeps growing until, bam! It creates a total traffic jam, completely blocking blood flow.
And this is when your body starts screaming for help. That classic, crushing chest pressure, the pain shooting into your jaw or down your arm, the sweating, the shortness of breath. Those are your body's alarm bells, blaring that the heart muscle is literally being starved of oxygen. Okay, back to the emergency room. The clock is absolutely ticking. The team there relies on 2 main tools to figure out what's going on, and fast. Because in cardiology, the saying is, time is muscle. And they mean it. Every single second counts.
The first and most critical test, the ECG. And get this, the goal is to have it done and interpreted within just 10 minutes of a patient walking through the door. It's an instant snapshot of the heart's electrical activity, and it can tell them right away if a major artery is completely blocked. All right, so based on that one test, that ECG, patients immediately get sorted and sent down one of 2 main paths. If the ECG shows these major changes called ST elevations, it's a STEMI. That's the big one, the most severe type, caused by a total blockage. If not, it falls into the NST-ACS category, which is usually a partial blockage. This one distinction, it dictates everything that happens next.
But the ECG is only part of the puzzle, right? Doctors then combine it with this crucial blood test for a protein called troponin. See, when heart muscle cells die, they release troponin into the blood. So a positive test confirms it. Heart muscle has been damaged. It's a myocardial infarction. If the test is negative, it's likely something called unstable angina. Still very serious, but maybe, just maybe, they've caught it before permanent damage set in.
Now, for a STEMI, that total blockage we talked about, the goal is simple, urgent, and absolutely non-negotiable. Restore blood flow to the heart, right now. This is a flat-out race to save as much of that heart muscle as possible.
The gold standard for opening that artery is a procedure called PCI. You've probably heard it called angioplasty. A cardiologist threads a tiny, thin catheter all the way to the blockage, inflates a little balloon to flatten the plaque, and then places a small mesh tube called a stent to prop the artery open for good. It's really amazing stuff. And the urgency here is just incredible. Hospitals measure their performance in what they call door-to-PCI time. That means from the moment a patient hits the ER doors, the goal is to have that blocked artery open within 90 minutes. Think about that. 90 minutes. Because every minute that ticks by, more heart muscle cells are dying. Success is literally measured in minutes. But okay, what if you're at a hospital that can't do PCI, or it would just take too long to transfer you? Well, there's a backup plan, fibrinolysis. These are powerful clot-busting drugs given through an IV. And the goal here is even faster, a door-to-needle time of just 30 minutes.
But here's the thing. Opening the artery is just winning the first battle. The body is still in emergency clotting mode, you know? It's ready to form a new blockage at a moment's notice. So to prevent that, doctors deploy a powerful cocktail of medications.
The first weapon they use is an antiplatelet. These drugs work by making the blood's platelets less sticky, so they can't clump together so easily. And the cornerstone of this whole strategy is good old aspirin, which they give to patients immediately. But aspirin alone isn't quite enough for this fight.
The standard of care is something called dual antiplatelet therapy, or DAPT for short. This combines aspirin with a second, more potent antiplatelet agent. It's a real 1-2 punch to stop another clot from forming. Okay, so the second part of the cocktail is an anticoagulant, like heparin. If you think of antiplatelets as making the platelets less sticky, you can think of anticoagulants as disrupting the chemical glue that holds a clot together. Together, they create this comprehensive, multi-pronged defense against another blockage.
So, surviving the initial heart attack is obviously huge, but it's really just the beginning of the story. The next crucial phase is life after the hospital, and that's where the treatment and the vigilance become a lifelong commitment. And here is a point that is so critical. Patients have to continue that DAPT regimen, those 2 antiplatelet drugs, for at least 12 months, no exceptions. Stopping too early dramatically increases the risk of that new stent clotting off, which could trigger another and often fatal heart attack.
And DAPT is just one part of a whole new lifelong routine. Patients will also be on beta blockers to ease the heart's workload, ACE inhibitors to protect the heart muscle, and a high-intensity statin to aggressively lower cholesterol and prevent new plaques from forming. All of this is paired with cardiac rehab to build strength and confidence.
It's pretty incredible, isn't it? Modern medicine can perform miracles, opening a blocked artery in minutes and prescribing these life-saving medications. But the lasting success, the prevention of a second event, a lot of that comes down to the daily choices and commitments made long after leaving the hospital. The journey truly is a lifelong one.